Hello, everyone. My name is Zohib Chaudhary. Today, we'll focus on the uses of public health surveillance by going deeper into some of the specific aspects that surveillance is used for. So, surveillance is basically information for action, and this slide displays the three public health core functions: assessment, policy development, assurance, which you can see on the outside of the circle. The multicolored pieces in the center represent the 10 essential public health services. Surveillance activity occurs as part of the assessment pieces, monitoring health and diagnosing and investigating diseases or health problems. So good surveillance provides data needed to give an accurate assessment of the status of health in a given population. Good surveillance can also provide an early warning of disease problems, so immediate control measures can be put into place. It can also give us information to design and plan public health programs and also information to plan and conduct research. So who uses public health surveillance? In this diagram, we can see the main users of public health surveillance. So at the local level and then at the federal and state level, so we can see at the local level, local health departments or services, emergency medical EMS, at the state level, state health departments, at the federal level, Center for Disease Control, CDC, Food and Drug Administration, FDA, National Institutes of Health, NIH, Centers for Medicare and Medicaid Services, CMS. So these are all places where in the U.S. Public health surveillance is utilized at the government, local, state, and federal level. Data can also be used by healthcare providers, such as hospitals, clinics, as well as healthcare providers from Department of Defense or the U.S. Department of Veterans Affairs, so VA. Surveillance data can also be used by data providers and users such as the Regional Health Information Organization, as well as Health Information Exchange, and by public health practitioners, representative of affected communities, as well as professionals and private nonprofit organizations in general. So all of these organizations, institutions, or agencies use surveillance to guide their programs. The major uses of surveillance can be depicted in here in 7 specific ways, and there are definitely more than what I'm presenting in here. So each box shows specific ways that public health surveillance can be used, and we'll go into a lot more detail and provide a lot of examples of each of these specific uses. So the first one in here is identify patients and their contacts for treatment and infection. That's one possible use. The second possible use is to detect outbreaks, epidemics, health problem, changes in health behaviors. A third possible way is to estimate the magnitude and scope of health problems, and this helps to estimate the resources that may be needed to combat them. Fourth possible use is measure trends and characterize diseases. A fifth would be focusing mostly on monitoring changes in infectious and environmental agents and support public health interventions that follow from the continued monitoring of this data. And ongoing surveillance can be used to estimate the natural history and often the impact of a condition over time. Knowing what to expect in terms of natural history aids in planning where to allocate resources. On this box here, labeled as number 6, we are seeing that surveillance can assess the effectiveness of programs and control measures, and continuing surveillance after an intervention can be used to evaluate prevention and control measures as well. And finally, developing hypotheses and stimulating research is another aspect where surveillance data has been used a lot. I'll provide some examples later on about this as well. So now we'll go deeper into each one of these 7 uses and provide examples. So one primary use, as we mentioned, is to determine the distribution and spread of disease in different population groups and recognize cases or clusters of diseases to trigger intervention to prevent transmission or reduce morbidity and mortality. This is done by identifying patients and who they came into contact with, which is useful during the treatment and intervention phase. An example of this is the work that was done nationally as the HIV/AIDS outbreak unfolded. Another more recent example is the contact tracing work that was essential during COVID-19 to control the spread of disease in the US and elsewhere. In some countries, cell phone apps were utilized to track, alert, and control the illness of COVID-19 within their jurisdiction. Surveillance at the national level is required to recognize multi-state cluster, of course. Surveillance can be used to detect outbreaks as well. And this is our second box previously. In this figure to the left, we can see illness onset dates of laboratory confirmed outbreak associated cases of Salmonella Thompson between May 2021 until early November 2021. And in the figure to the right, we can see the number of persons infected with the outbreak strain of Salmonella Thompson by state of residence and number of cases per state. Salmonella Thompson is a relatively uncommon serotype, not typically associated with seafood. Previous outbreaks have been associated with beef, chicken, and vine stock and leafy vegetables. During May and October 2021, 115 people in 15 states became ill with S. Thompson. Most patients reported seafood consumption in Colorado before illness onset. The outbreak strain was identified at a single seafood distributor and processor in Denver, where opportunities for cross-contamination due to inadequate sanitation were identified. The distributor issued a voluntary recall of 16 seafood items with high potential for contamination and completed remediation actions after the surveillance investigation was conducted. This outbreak illustrated the importance of effective cleaning and sanitizing practices and implementation of controls. When multiple products are recalled during an outbreak investigation, collaboration between public health agencies and implicated facilities can help provide food safety information to restaurants, retailers, and consumers, and to ensure disposal of all recalled products. Surveillance can also be used for outbreaks and epidemics investigation, and this is another examples of detecting outbreaks. So the figure to the left shows the number of reported cases of foodborne botulism from 1984 to 2004, and the figure to the right shows a continuation of the data until 2015. Botulism is a severe paralytic illness caused by toxins produced by Clostridium botulinum. Exposure to toxin can occur by ingestion, foodborne botulism. There are definite peaks in the number of cases of botulism. And there are labels in here also showing the related foodborne outbreaks. In 2015, an outbreak associated with home canned potatoes in a potato salad caused 23 cases, while in 2011 and 2012, 2 outbreaks was caused by Pruno. Pruno is an illicit alcoholic beverage brewed by prison inmates. So we can see that the number of foodborne botulism cases caused by ingestion of preformed toxin was at the lowest level in 2010 and again in 2013, but has started to rise again in 2014 and 15, and we are seeing some very high numbers in here. Um, Another use is to establish baseline disease, another use of surveillance. The figure above shows incidence per 100,000 people. In this line graph, you can see the number of salmonellosis and shigellosis cases in the United States from 1985 to 2015. The solid line above is for salmonella infection, and the dotted line below is for Shigella. Although incident rates of salmonella infection have remained relatively stable since the early 1990s, incident rates of Shigella, on the other hand, in the same periods have followed a general increasing trend. Um, um, During 2009, multi-state outbreak of salmonella were linked to aquatic frogs, right there, 2009, and consumption of alfalfa sprout and pistachio and peanut butter. This surveillance is also important during non-outbreak times to provide information about baseline level of disease. So these baseline measurements provide important information to public health officials in monitoring health at a community level and serve as important references in any future outbreaks. Surveillance can also helps to detect health behaviors and changes in health behaviors. So in 2009, in 2009 right here, the cesarean rate was the highest ever reported in the United States. The number of cesarean births increased from 1996 to 2009, and then is slowly stabilized at around 32%. Which is very high. So there were about 1.4 million cesarean births in 2007, which represented about 1/3 of all births in the United States, following a decline in the early 90s to 2009, early 90s. The cesarean rate started increasing significantly up until 2007, and then it followed on until 2021. As we can see, it's still very high at about 30%. Surveillance can also help us to estimate the magnitude of a health problem, scope and mental health problem. In here, you can see results from the 2017-2018 National Health and Nutrition Examination Survey using measured height and weights. And this indicates an estimate of 42.5% of US adults aged 20 and over have obesity, including 9% with severe obesity, another 31.1% severe overweight. So in here, this is expressed as BMI, and BMI is weight in kilograms divided by height in meters squared. And this is the common measure to classify obesity and overweight. Overweight is defined as a BMI of 25 to 29.9. Obesity BMI is above 90, and severe obesity BMI is above 40. Excuse me. So surveillance can also be used for understanding distribution and spread of health events. And here we can see this West Nile virus spread in the US from 2000, 2001, 2002, 2003. And you can see this classic example of looking at the spread of West Nile virus, starting from the East Coast, going all the way up to the center of the United States, and then eventually up to the West Coast as well. Here you can see the number of incidences in the 2000, and then the rise by 2002, which is shown in here. So such distribution and spread of health events such as West Nile virus, we can gain this by doing surveillance. Surveillance can also use to measure trend. For example, in here, the trend of Lyme disease. We can see these two maps that shows the reported cases of Lyme disease in 2001, which is in here, and 2019, which is in here, for the areas of the country where Lyme disease is most common, which is in the Northeast and Upper Midwest region. It is clear that this, by looking at this map, that Lyme disease spread and trend has significantly increased from 2001 to 2019. And this type of information can, with time, we can tell by doing surveillance. Another use of surveillance is to monitor change. In this graph, we can see the number of cases of pertussis or whooping cough in the US from 1922 through 2000. So what we are seeing is the significant decline of substantial cases of whooping cough. However, if you start looking closely in here and you blow this region up from 1980 to 2000, the trend it's actually going upward all over again. And so what action would you take on the basis of this information? This investigation revealed that weakening immunity to pertussis after primary vaccination was part of the reason for the increase. Consequently, new vaccination recommendation stated that adults should receive a booster vaccination to prevent again the rise of this disease all over again. Another use of surveillance is for evaluating control and prevention measure. And this graph illustrates how by using surveillance, we are able to evaluate specific control and prevention measure. In this case, checking if vaccination were effective in reducing measles in Americas during 1980s to 1997, as measles vaccines coverage in the early 80s started increasing in the Americas to about 50%, we saw a rapid decrease, almost a 40% decrease of cases from 250,000 to 130,000 to 150,000 almost immediately. But then it started rising again in regions where vaccination coverage was poor. The catch-up campaigns during the late 80s and early 90s were critical in reducing the cases again. And finally, the follow-up campaigns assisted in increasing coverage to above 80% of vaccination throughout the nation, and the cases came down very fast following that. Finally, surveillance used in hypothesis testing and research. So in here we can see surveillance usage in hypothesis testing. A hypothesis can look into relationship between two variables or explore if-then relationship between variables. So during 2020, observed incidences of infections caused by enteric pathogens decreased 26% compared to 2017-2019. So, and this was during the COVID period right here. So infection associated with international travel significantly decreased as well. The extent to which these reductions reflect actual decreases in illness or decreases in cases detection is unknown. The 26% decrease in incidence of infections caused by pathogens transmitted commonly through food during 2020 was the largest single year variation in incidence during the 25 years of food net surveillance. So widespread public health interventions implemented to prevent SARS-CoV transmission might have contributed to this decrease. Other interventions, such as restaurant closures, might have contributed to the decline in incidence. However, higher than usual proportion of infections might have been undetected because factors such as changes in healthcare seeking behaviors and broader use of telenet might have limited the number of stool specimen tested. So maybe there's also an underreporting going on. So there's a lot of hypothesis testing that with this data of surveillance, we can generate from here. Again, using the same data set from FoodNet, and FoodNet conducts active population-based surveillance of laboratory diagnosed infections caused by Campylobacter, Listeria, Salmonella, Shiga toxin producing E. coli or STEC, Shigella, Vibrio, and Yersinia. And these are reported in 10 sites covering approximately 15% of US population. And in here, we can see that, again, significant decline of many of these foodborne pathogen and the trend with time. So 17 to 19, more or less even, and then a significant drop in 2020 during that COVID period. So this type of surveillance data can stimulate research of what led to this significant decline of all of these foodborne illnesses. Was it underreporting, or was it some of those measures that were done during COVID? And to understand those measures and to implement them for effective reduction of diseases. So that's all. Thank you.